As we all know, it's a big challenge because this is a disease that has not been well known before, and actually there are no studies that they can provide us with evidence-based in terms of the best practice. So my task will be to share some of the highlights on the currently available best knowledge and clinical experience available. We'll also share case studies on what we have been doing. And to start off, as I've said, we don't have studies that have been there before that we can use to be able to manage our patients in terms of nutrition. But here on this side in KNH, we have been trying to find best available knowledge. And one of the sources we have been consulting is Aspen. So we'll share practical guidance on nutrition management in patients with COVID-19, particularly in critical care. Currently, patients who are very sick, who require mechanical ventilation, they are taken to IDU units, that is in infectious disease units, which is another extension of ICU. And it has been interesting to be able to find how these patients have been responding. But before we go to the case study, there are some 10 recommended steps that should be observed from Aspen 2020. I'll not go through all of them, but I'll pick the highlights and particularly what we have been doing. And one of the recommendations, as we all know, is that once a patient, when you are planning for nutrition care, the first and foremost thing is to do nutrition assessment. Aspen is recommending to use MAST and nutrition risk screening 2002. But we find that it is recommended to have bundle of care because it's not very good to keep having contact with the patient. So currently here we are utilizing nutrition focused physical examination and diet history, particularly in the first few days, so that we can be able to determine patients who are at risk or those who have malnutrition. We all know 5 components of nutrition assessment. And for example, nutrition focused physical examination, we are able to see patients, how clinically they are presenting. I'm not sure whether you are getting to see some of the pictures on my slides. Are you there? Thank you. So this is an example. By look, you can examine patient from head to toe to be able to tell loss of muscle loss and subcutaneous body fat loss, and you can be able to categorize where the patient belongs, whether the patient is having severe malnutrition, mild to moderate, or well nourished. Remember this objective assessment. Now, nutrient requirement for these patients, as per the provisions of Aspen, patient with polymorbid condition who are more than 65 years old, it's recommended to provide 27 kilocalories per kg body weight. While those who are underweight, there is some increase up to 30. Remember, these are predictive equations. For macronutrients, protein starts from 1 gram for older persons, but it's recommended to provide more than 1 gram for patients with multiple conditions. And for fats and carbohydrates, if patients are ventilated, you have to check very well what's happening so that if the patient is retaining more of carbon dioxide, you can be able to adjust the feeds so that the fats to carbohydrate ratio correspond appropriately. Now, there have been a lot of debate in terms of whether do we need to provide uh, multivitamin supplementation or micronutrient supplementation. But from the recommendation by Aspen experts, as you can see there, they are saying that micronutrients play a very important critical role in terms of mitigating viral infection adverse effects. And therefore, on these grounds, it's recommended where if patient is not is underweight, to provide vitamin A and vitamin D and other micronutrients that may be deemed necessary. Okay, on this side here, it has been interesting to note that patients supplemented with vitamin C and zinc uh, have better prognosis, but remember, there are no studies available. Okay, patients mostly we find that they are not able to feed orally adequately. And therefore, for those who are able to feed orally, but the intake is not adequate, they are supplemented. But the recommendation is that at least to provide 400 kilocalories, and the protein should not be less than 30 grams, and for a span of period of 1 month. Now, for patients who are not able to feed orally, it's recommended, of course, to start to use the gut when it's working. So always we start with enteral nutrition and gastrostomy by use of with PEG is the most recommended, because these patients, if they are ventilated and they have difficulty in breathing, the outcome from the expert recommendation is that if gastrostomy can be put in place, it will work very well. But for energy equation provision, as I said, there is a use of predictive equation. When you determine the energy needs for patient on a daily basis, the starting of this energy provision should be gradual. Actually, the patient by day 4 should be able to be receiving 80 to 100 grams, 100% of total energy requirement that need to be provided. For proteins, it's very interesting because we always know that patients should receive at least 1 gram of protein in critical illness, from 1.2 grams per day per ideal body weight. And we find here that we need at least 1.3 grams of protein per day per ideal body weight. That should, and the target on the upper side should be met by 5th day. In case there is intolerance of enteral nutrition support, initiating TPN should be considered, but cautiously. And for patients who have been who are extubated, there is also some incidences that we find they have difficulty in swallowing. Therefore, it's good to assess patients to see whether they are able to swallow appropriately and take adequate amount of food. And for this, it means that the texture of food should be well considered. I think I want to stop at that point. These are, remember, they are highlights from Aspen. I would encourage you to go and have that document, read it. It's very detailed, but in a nutshell, this is what is available. Thank you very much.
Thank you, Alexander, for that presentation. And we'll go through the document from Aspen. We also, during one of the presenters will share with us documents from Kenya so that we understand. But right now we'll hand over to Jack to take us through a case study, I think. And then we have the team from Innocent Kinoti from Kenyatta University, then Daniel Muteti from Coast, and Nancy Mali from MTRH. Remember to put your questions in the Q&A section, and the team will be responding to them as we continue with the presentation.
All right. Okay.
I apologize for the slight itch. Give us 1 minute to sort it out. But in the meantime, I think we could be listening to Innocent. Oh, okay, it's there. All right.
Good afternoon. My name is Zakonyama. As you heard, I'm presenting a case one on a patient that was confirmed COVID-19, but had pneumonia initially. This patient was admitted on 10th in the month of June with is a 30-year-old referral from Baghdadi Hospital, where he was admitted with history of cough, sore throat, running nose, and difficulty in breathing, and also he had general body malaise. We took over. He could take over-the-counter medicine with no improvement, and a day prior to admission to Baghdadi Hospital, the patient has dyspnea, which was worsening. Then the BPs were 120 over 70. The temperatures was above 37. The RR was 29. SOPs was around 80. SPO2 was 88%. We managed to go through the food and nutrition history, where on admission, the patient was able to, we learned that the patient was able to feed orally, but the intake was poor due to the persistent cough. On the nutrition-focused physical examination, the patient was well defined in terms of temple. The eyes were slightly bulging. Other examinations were deferred due to the risk associated with the COVID, especially when now it comes to close contact during physical examination. However, clinically, the patient presented with normal nutritional status. The patient was on oxygen therapy, and he had a GS of 15 over 15. The biochemical data, we were able to take, they were able to be determined thrice, where most of them were normal, apart from maybe the sodium, which were reading low, and urea in the first test was already low also. The day two, upon admission, this is when the patient tested positive for COVID-19. Anthropometric, as I already mentioned, they were deferred, but we had an ideal body weight on estimate that was 62 kgs. Nutrition diagnosis, we managed to identify that there was inadequate nutrient intake related to poor oral intake as a result of persistent cough, whenever attempts to feed, and when off oxygen mask as evidenced by food records showing less than 50% of the food intake of total food portion served per meal. Nutrition intervention, the prescription here was we were targeting 2,100 calories, where we could give 62 grams of protein, 315 of carbs, 68 of fat, and then now the type of diet we recommended was high protein, high calorie. On monitoring and evaluation, that is the two, the patient was put on hospital diet to provide required calories and nutrient needs. For breakfast, we could serve special milk at around 500 mils. 10 a.m. snack, that is special milk, 300 ml. Then for lunch, there was a standard portion as per the hospital menu. 3 o'clock, we served 300 ml of porridge. And supper, standard portion, it is as per the hospital menu. Upon review, patient oral food intake was suboptimal, still had persistent cough, and only tolerated well liquid diets. On day 3, the patient was provided with oral nutritional supplements at 3 servings of Ensure per day. That was around 690 kilocalories as a snack. On day 8, because we could not do each day, so we only identified, we skipped some days, but on day 8, upon review, patient had improved tolerance on solid foods with good tolerance of Ensure supplement. And we could also titrate down to 2 serving because now the patient was, the oral intake was improving. So we went down to 460 kilocalories as opposed to the earlier. Patient also received diet counseling. On day 12, patient oral food intake had improved remarkably, but was still on oxygen. And we also identified that USCs were very normal. Thank you. That is the presentation, case 1.
Hello. Yeah, thank you very much. We had another case 2. This case, it's where a patient had polymorbid conditions. The patient was HIV positive and was having end-stage renal disease on biweekly hemodialysis session. Client history when we assess the patient, we found that the patient had fluid overload, had fever, vomiting, and some mild edema, had difficulty in breathing, but well saturating. So this patient was not put on, was actually breathing room air. Food nutrition history indicating that the patient could not feed orally because of appetite. Actually, the patient had episodes of vomiting and nausea. As you'll see, the lab works, the urea was very high, and that's the reason why the patient was actually not able to feed well. However, the patient's nutrition status presented with mild wasting, and patient's lab works, as I've said, creatinines were very high, but electrolytes were within the range. This patient was from medical ward. The patient was admitted some few weeks ago, but came to IDU on 20th, and day 2, that's when the results were confirmed that the patient had was COVID positive. We provided an ideal body weight estimate of 60 kgs, and our working diagnosis, nutrition diagnosis, was that inadequate nutrient intake related to insufficient all food intake as indicated by diet history upon assessment. Now for this patient, we decided to put her on renal diet. whereby we anticipated to provide at least 2,000 kilocalories, 72 grams of protein, potassium not to exceed 2,300 milligrams, and actually also sodium not more than 2,400. Same to phosphorus, not exceeding 1,000 milligram. We put this patient on a renal diet. We ordered renal diet from our diet kitchen. And on day one, as you can see, after planning, still the patient could not feed, was doing not very well in terms of oral intake, but we encouraged the patient to feed. We provided some enriched porridge and milk, snack at 10 and at 3, and the patient tried to feed during the supper and lunch, standard portions. But on day 2, we decided to provide oral nutrition supplementation that could be able to provide high energy, high calorie was ensure. And we decided to do 2 servings. We not want to do more than 2 servings at that point because of potassium and phosphorus. Remember, this is not a very disease-specific supplement. So at that, we were able to maneuver. And by day 5, patient oral intake was improving significantly. Though a patient would request, was feeling sensation of thirsty and would want to take a lot of fluids, but based on the patient condition that this is a renal case and was doing hemodialysis session twice a week, we were able to advise the patient on fluid management. And on day 9, patient's oral intake still improved further, though still patient was by that time was put on was on oxygen, but on lab results they improved remarkably. And by day 9, patient was very stable and was transferred to Bagavi. We normally have very critical ill patient for stabilization at Kenyatta. So this was also another success story. And as we speak now, the patient has even improved taking solid foods and it's doing very well. Thank you very much.
Thank you, Jacob and Alex, for that presentation. I'd like to invite Kinoti from KU to take us through, and also I'd like to ask our panelists to address the questions in the Q&A. You can just type your answers. Due to time, we might as well as continue addressing the questions and answering them in the Q&A section. Kinoti, please take over.
Thank you. Hope everyone can hear me. Trying to share my screen.
Okay.
Is it visible?
Yes, we can see your screen.
Okay, thank you very much, Mercy, for the opportunity to be able to showcase how we manage patients, COVID patients at Kenyatta University Teaching and Referral Hospital. Since our operationalization late last year, I'd like to inform everyone that we have a 650 bed capacity equipped with state-of-the-art medical amenities. The hospital is well equipped to offer oncology, trauma and orthopedic, renal, among other services, including
Hello, Kinoti. Hello? Hello?
Hello, Mercy. Can you hear me?
Yes, Kinoti, we can hear you.
Well, I had started. I'm sorry for the inconvenience. I'm not sure what that the problem was.
It's okay. Are you able to
Sorry.
share your screen?
Yes.
Okay, good. We can see
I'm
it.
not
Okay.
sure. At what point was I lost?
You can just start again and
Okay.
go through it briefly. Okay.
Okay. All right. Yes. All right. So we are. There is sufficient evidence that demonstrate immune response can be weakened by inadequate nutrition. And nutrition management is very important to enhance immune response for an infected person against RNA viral infections such as COVID-19. Therefore, today I'll be showcasing one of our case study and give out among the recommendations that we went through coming up with a plan on managing the patient. Okay, in a KU University Referral Hospital, the ICU has a capacity of holding 24 patients. Since our first case on 3rd April, we have been able to cater for 34 patients in ICU. However, the current capacity, due to the resources that are available, we have been able to see a maximum of 7 patients. A bit of demographics of the patients that we have been seeing at ICU, their age range from 26 to 84 years. Of all these 34 patients, 10 have been females while 24 have been men. Most patients who have ended up in ICU with advanced pulmonary illnesses have been polymorbid, with 38% of the patients being diabetic, 21% be having renal insufficiency, 9% being hypertensive, while 35% have been suffering from other illnesses that took their immunity down. Therefore, we need, as we manage our patient, we have pertinent principles that are recommended by ESPEN and also the Ministry of Health, especially the preservance of personal protective equipment. We are all aware of the stress COVID has had on the economy and at a global picture. Then again, we are doing bundled care, and this means that we try to limit exposure to the patients while we're taking care of them. Therefore, as my colleague Alex has indicated earlier, we consider medical nutrition therapy for all patients in ICU, and this should be initiated especially if the patient is intended to stay in the ICU for more than 24 hours. There is individualized clinical assessment as well, and this makes it possible to give patient-centered care. As it was earlier mentioned also, oral diet is the main goal and of most importance while starting to feed the patients. And only if the patient can't eat their food orally, it's when we now consider enteral nutrition. And with any contraindication of starting enteral nutrition, we start parenteral nutrition in critically ill patients. For non-intubated patients, oral nutrition and oral nutrition supplementation should be considered before we start enteral nutrition. And patients with dysphagia, we can now consider modifying the texture for the food to be soft so that they can eat orally. Then another recommendation will be key to note is that when we receive patients in ICU, especially like in the case I had in Kenyatta University, is that we normally don't have the feeding history of the patient. And therefore, it is important to note that in an ICU setup, it is critical that we start at a hypocaloric diet, which is a diet that provides less than 70% of the caloric requirements. While this is a fatal, it's a potentially fatal syndrome that manifests in shifts in fluid and electrolytes. In many cases, it is misdiagnosed, especially in the general ward, and handled badly. Therefore, for our case, the patient was a 50-year-old male with anthropometric measurements 60 kilograms, 157 centimeters, BMI of 24, which is normal. Medical diagnosis on admission was DKA in a newly diagnosed diabetic patient, hepatitis C positive patient with AKI and COVID-19, as well as meningitis and or cerebral malaria. While he was presented, there was chief complaints of convulsion, difficulty in breathing for 3 days, reduced level of consciousness. We had a GCS of 5 out of 15, unable to feed orally because of difficulty in breathing, and there was no previous history of mode of feeding. The patient was referred from a peripheral facility where he had been taken by Good Samaritans. There was generalized tonic-clonic convulsions for unknown durations and unknown episodes. There was no history of fever, cough, sore throat, trauma, exposure to COVID-19, or travel to malaria endemic zone. This was hard because the patient was presented with low level of consciousness. It was hard to assess. The medical interventions that were key for nutrition intervention was there was a NG tube insertion and also a central venous catheter inserted. The patient was intubated and ventilated. Also, it is important to note that the potassium levels were low. Urinalysis was ketonuria, glyceria, hematuria, and the UECs is as follows. Therefore, I'll take you on a path that we took through the 15 days. These are the nutritional goals that we had. Using the SPN recommendations, we used 35 kilocalories per kg and used a weight-based formula. Coming up, the goal would be 21,000 kilocalories in 24 hours. While we are giving a protein at 1.3 grams per kilogram, this patient was diabetic, and therefore we started him on a diabetic enteral feed, 1400 mils being the goal. However, since our goal is to start on a hypocaloric enteral nutrition, we did 350 mils in 24 hours. That was giving us 25% of the caloric requirements for this patient. It is important to note that the HbA1c of this patient on admission was 17.1%, which is almost triple that of a normal patient because the cutoff is at 6%. Patient was put on insulin therapy and hypocaloric enteral nutrition. Therefore, it is important to note that the patient was experiencing hypokalemia, hyponatremia, high levels of chloride, urea, and creatinine. Patients was put on IV fluids. IV fluids and potassium replacement therapy to correct the electrolyte. This is on day 2. Day 3, the DKA had resolved, insulin was reduced, and also normal saline, since there was hyponatremia, was stopped. However, the patient was not tolerating feeds well, warranting gradual use. Back to differ. The patient was tolerating the feeds well, warranting gradual increment of the food volume in 24 hours. And that's why we changed now on day 4, we changed to 590 meals in 24 hours. By day 6, we had achieved 860 meals in 24 hours, achieving 60% of the caloric diet. Patient had undergone dialysis due to deranged electrolytes. However, we noted that there was elevated LFTs. That was an indication of multi-organ failure. There was the patient was oedematous by day 6. Patient had persistent oliguria, elevated ECs. It was also noted that feeds given were unabsorbed for over 8 hours on day 8, and LFTs indicated worsening liver function. This therefore warranted supplemental parenteral nutrition, and as you can see on the slide, from day 9 there was lowering. We lowered the enteral nutrition to 240, which basically is a trophic feeding rate that is minimal for administering nutrients having beneficial effects, such as stimulating brush border enzymes, preserving intestinal epithelium, enhancing immune function, preserving epithelial tight cell junction, and preventing bacterial translocation. However, with the TPN, we were able at least to reach up to 58% of the nutrition requirements. By day 11, patient had developed bleeding in the gums. He had undergone dialysis 3 times, had received 2 pints of blood intradialysis. The LFTs had improved for a day. He had deranged. The LFTs remained deranged with hypoalbuminia and high creatinine and urea levels. Malabsorption persisted even after dispensing prokinetics to the patients, who was anuric, which is an output of less than 100 on day 13. On day 14, the patient remained very sick with reduced level of consciousness, and it reduced from 5 to 3. The patient was hypotensive and responsive to fluid therapy, cold extremities, and an apnea test was done unsuccessfully that warranted halt of aggressive therapy. On the 15th day of care in ICU, a second test of brainstem function was done successfully, and the patient was pronounced brain dead and was deceased later in the day. Among the challenges that we faced in ICU in giving of care is, as indicated earlier, there was no specific COVID-19 specific data guiding on any specific additional supplementation over the standard ICU requirements. So supplementation is only done on suspicion of deficiency on admission. Other studies have contradictory conclusions, especially with other viruses, such as coronavirus. There is also a problem when handing over patients, especially when they are referred from peripheral facilities. There is no feeding or nutrition history from the hospital. Therefore, it might lead to increased risk of a feeding syndrome, then long duration of underfeeding that may eventually lead to prolonged stay in hospital. I'd like to thank you for the opportunity to present my case. Back to you, Marcel.
Thank you very much, Kinoti, and you brought out a very pertinent issue about handing over of care of patients. As a patient is being referred to another facility, there's a lot of crucial information that might not be handed over. So we appreciate that you brought that out. And it's something that all the participants who are listening from other institutions, from other counties, it's something that we can ponder over. How best do we hand over the care of our patients from one facility to another? How much information do we usually give in that referral form, in that discharge summary? So these are some of the things we need to consider. And thank you so much for that elaborate presentation, Kinoti. Your presentation of the patient from ICU was very good and concise. It's unfortunate we lost the patient, but we can see the effort that you put in trying to take care of the patient. Now we'd like to hear from Daniel Muteti from COST, just to hear what they're doing and how they're doing it right. And I hope Daniel will be able to address issues of patients who are not in ICU. What advice are we giving them? What are they going home on? What information or what advice, nutritional advice are you giving them? And also the patients on home-based care. So Daniel, karibu sana.
Hello and welcome my presentation. Clinical nutritionist. Optimal nutrition for patients with COVID-19 disease.
Hello, Daniel.
Yes.
We can't hear you clearly.
Hear me, Daniel?
But we can see your slides. We can see your slides.
You can see my slides.
Yes, we can see your slides, but we can't hear you clearly.
The problem is the speaker. Are you getting me well?
Hello?
I continue with my presentation.
We still can't hear you clearly. Hello, Daniel?
Yes. Are you getting me now? Well,
we're still having challenges hearing your voice clearly.
you cannot hear my voice clearly.
Yes. Maybe we could move to Nancy as we work on your audio on your end. Is that okay? Then we'll come back to you. Okay. Nancy Emali from Moi Teaching and Referral Hospital. Hello, Nancy.
Hello.
Yes, you can proceed with your presentation. We'll come back to Daniel.
You can see my slides.
No, let me just, Daniel, please stop sharing your screen so that Nancy can share her screen. Nancy, you can share your screen now.
Are you able to see it?
Not yet. Yes, I think, yes, now we can see it.
Good afternoon, everyone.
Good
I'm
afternoon.
Nancy Imali, not from MTRH, but from Uasin Gishu County, Kamalela Isolation Site. I will present just 2 cases. We've generally only had mild cases. So all our severe cases actually referred to MTRH. So we have Uasin Gishu County has 3 isolation sites. At Kamalel, we have had 30 COVID-19 patients with 25 discharges. Currently, we have 7 COVID confirmed patients. Of them, we have 6 males and 1 female. So comorbidities managed included diabetes and hypertension. And most of our cases were symptomatic and mild cases. We've not had severe cases.
Hello, Nancy.
Hello.
Could you please put the full screen? Yes, you can only see half your screen, so maybe the slideshow will be good.
The slideshow?
Yes, the full screen. Thank you.
Okay. So I had earlier said most of our cases are asymptomatic and mild cases. So our severe cases actually referred to MTRH for further advanced management. So for the mild cases, generally we use the general hospital menu, which include 4 meals a day, and they include an animal source food, vegetables, fruits, forages, and other carbohydrate-rich foods. We give them lemon and ginger water at 4 p.m. When it comes to serving, we use disposable plates and cups. These are used and disposed of immediately after use. Currently, we are using also plastic cup for the patients, which are cleaned and kept by the patients. As I've said, our patients are mild, so they're able to also take care of themselves. So I will present one case. We've identified as patient A is a 46-year-old male, admitted on 21st June 2020. The weights we put here are estimated weights because when these patients were admitted in, we were not able to take their weights and heights. But we were able to ask them through, because our counseling was done by phone, to estimate what is their weight, their height, and the BMI calculated. So whatever we have is an estimated. So their medical history, this one was a DM, non-DM for 5 years. The patient was stable, blood sugars controlled, and they were on azithromycin, cetirizine, and metformin. So nutrition counseling was done by phone. This was an interesting way of counseling, which we are not used to before. So we'd call and go through the patient step by step, what they have been eating, how they have been being managed. And we realized there was an intake of excessive starches. So actually we can see the patient was obese. So our plan was weight loss through diet and exercise. So we actually just prescribed a plate model. And then the outcome, the patient is still admitted. The number of days stayed in since admission now is 9 days. So those are the fasting blood sugars for the patient. We put there for a number of days. It has varied from 6.2 to 5.2. So generally would say the patient is stable, able to take care of themselves, move around, do exercises. So the second patient is a 27-year-old female, was admitted on 14th May 2020. Again, this is an estimated weight. So the BMI there is at 24.5. The sneezing, the mission. So the drugs was put on was azithromycin, cetirizine, and ceftriaxone. Nutrition counseling for this patient was done person to person, observing a social distancing, ensuring I was in a mask, and the patient was an N95 mask. So plan, we used the normal hospital diet. The patient was discharged home on 10th of June 2020 after turning COVID negative. The number of days stayed in was 28 days. So thank you. So I would say in general, we've just had mild cases and asymptomatic cases in our center. And our plan is any severe case is referred to MTRH. Thank you.
Thank you, Nancy, for that presentation. And we apologize for the wrong introduction. Nancy is from Uasin Gishu County, Kimalel Isolation Site. Thank you for your presentation, Nancy. Daniel Moteti. Nancy, you can stop sharing your screen. And Nancy, I like the way that you adopted the phone counseling consultation. The first patient the first case study, you said that you did your nutritional counseling by phone. It's good that you adopted technology at your site, and it's helping you out to be able to continue addressing patient care and patient needs.
Thank you.
Yeah. Daniel, are you ready?
Yeah, are you hearing me well now?
Hello, Daniel.
Yes, I am experiencing the same problem.
Okay.
The first presenters. The first presenter, I could hear him very well.
Yes.
So I don't know what's happening. Hello.
Hello?
Are you getting me well?
No, we are not, unfortunately. Daniel, I'm being advised by our IT person that if you're using earphones, you can remove your earphones and we see whether we can hear you if you use the device's speakers.
Speaker.
Hello? Hello, Daniel.
Are you getting me now? Can I continue?
It's a bit better. We can try and see. Yes, you can continue.
Thank you and welcome to my presentation on optimal nutrition for patient COVID-19 disease. This is from General Hospital.
Daniel, unfortunately, it seems not to be working out. We'd really love to hear your presentation. Hello, Daniel.
Yes, I'm getting you.
Yes, we'd really love to hear your presentation. I know you have a very fantastic presentation for us, but unfortunately, your audio seems to still have some challenges. Do you have another device near you that you can use?
Let me use another device.
Okay, so in the meantime, we can be doing the Q&A question and answers, and then we'll come back to you once you get another device. Is that okay?
Thank you.
Okay, thank you. I'm also seeing Alan Koch is saying if you're inside the, Daniel, if you're inside the Costs General ICU, the network is poor inside the ICU. Maybe you can step outside the unit.
Yes.
Somebody else is also suggesting that you exit and rejoin. So we'll wait for you. We'll wait for you. I know your presentation is pretty good and we'd love to hear what you're doing in costs. So we'll give you a few minutes to work on your network on your end. But in the meantime, we'd like to do the question and answer section. And I'd like to ask the team that are presented, that is Alex, Jack, Kinoti, Nancy, and Mercy, who's also here with us. There's something that we've totally missed out in this presentation. We've not talked about supplementation. We've hinted briefly at it. So I really wish one of you would expound on it, vitamin supplements, because once COVID once the outbreak started, we saw quite a number of people buying vitamin C, buying vitamin D off the shelves, people having vitamin A supplements. If you go to the pharmaceutical technologists or the pharmacists that are on this session, if you could ask them, I'm sure they'd tell you that's their best seller for the last 3 months. They're selling out more supplements than the other medication. So maybe you could take us through that briefly. And also malnutrition and COVID-19. Right now we're having families who are at home. We're having children who are at home. The feeding programs, probably if there were some in some of them faith-based organizations or in some of the government schools, right now they're not happening. So malnutrition and COVID, I think, is also an area that you can shed some light on so that whichever county somebody is working at, we have locusts that ravaged our crops. Agriculture, we really don't know how we'll do, whether we'll do very well in this year because of all the challenges that we've had, although we've had quite a bit of rain. But maybe you could also expound for us about the feeding. How do we feed a patient who has malnutrition and also presents with COVID-19 at the same time, especially pediatric cases? Then there's a question also about lemon water. Nancy, I'd like to ask you to respond to that because you told us you're giving your patients lemon and ginger water at 4 p.m. So should we advise our clients to continue taking that? Should we advise our relatives? Should we also consider taking a lot of lemons? I'm seeing lemons being sold everywhere nowadays. So is it beneficial to us as a preventive measure or also part of the treatment? Then Simon Aurora is also asking about the type of food we'll recommend to the general public to enhance their immunity. So that's also a question that we may need to address. I'd like to ask the team to respond to those few questions before we continue and before we look for Daniel to come back. We'll start with Alex. Maybe you can tell us about vitamin supplementation together with Jack. And Marcy can take us through malnutrition, and Nancy can tell us a lot about the lemon ginger water.
Hello, thank you very much. On the issue of supplementation, actually, there is notion that micronutrients supplementation may provide an advantage to patients who are suffering from COVID-19. And based on the best knowledge and clinical experience, we find that micronutrients, patients with low levels of certain micronutrients like vitamin A, vitamin E, B6, 12, and also trace elements like zinc and selenium, they have associated adverse clinical outcome during viral infection. And therefore, as a general recommendation, as a part of general nutrition approach for viral infections, it can be prevented using by provision of adequate vitamins and nutrients, as they have been seen to mitigate the negative impacts or adverse impact associated with any viral infection. On these premises, therefore, that's why there is a general agreed recommendation that the patient, those patients who are underweight, especially malnourished patients, because there is likelihood to have deficiencies in these micronutrients, it's important to supplement, but notably vitamin A and D and other micronutrients that may be deemed necessary. I don't know, Dr. whether I have
Yes, thank you. Thank you, Alex. You say there's no confirmatory evidence, or there's no evidence that they're beneficial. We appreciate that honesty. Mercy, is there anything you'd like to add about the vitamin supplementation and also malnutrition, especially babies presenting with malnutrition and COVID-19?
Malnutrition and COVID-19, and we see that under Oh yes, you can now hear me. I was tackling okay. Yes. They have underage people have weaker immune system and be at a greater risk of severe illness due to virus, that is COVID-19. And at the same time, poor metabolic health, including obesity, diabetes, and it depends also with environment whether people are able to get this food locally. And also we can imagine the COVID-19 and the economic impact that has put so many families. So there are some community-based organizations that they used to provide for us food for various, especially school programs. And now that schools are closed, we are at home with our children, and yet we are not able to provide all the necessary food. But what we are emphasizing more as nutritionists is that we use the locally available foods. If possible, if you have a small area or are living in an area where there is a small land, we can practice kitchen garden and for us to combat the impacts of COVID-19. So good nutrition is essential, part of individual defense against COVID-19. Thank you.
Thank you, Mercy, for that response. If a baby comes with malnutrition and COVID-19, are we still giving the same nutritional dietary requirements as we were before, or is there anything that is changing for this baby?
For the baby with a COVID-19, it depends on the nutritional status of the baby. Because there's no specific food for COVID-19, however, we need to treat the nutritional complications that the baby has, especially the growth monitoring. We can keep on taking the weight of the baby, assessing the baby, so that we meet their nutritional requirements. Thank you.
Okay, thank you so much for that, Mercy. Nancy, tell us more about the lemon water. And there's somebody who's also asking how effective was the phone call consultation? Is it feasible? Does it work? Somebody's asking about the client's responsive and whether the hospital provided you with airtime to have that discussion with the patient.
Thank you. So about the lemon water and ginger, I think originally when we started, we had just provided the other fruits. But our patients also demanded, the reading around, and we thought a lemon is just again a fruit. It will still supply vitamin C. It has good antioxidant properties. So we thought it's good to provide for them because it poses no harm to our patients. So apart from just our normal management, the psychosocial support, we try to provide for patients some of the things they would require that are within our means as a county and at a hospital to provide. So that's why actually we included the lemon water and ginger at our 4 p.m. meals. About the phone calls, they were effective. The county provided for us the Airtel. Luckily, most of our patients use Airtel, which is a free, we call it almost a free call because you only lose very little money to call. And like I would say, would inquire if they can know their last weight taken, their height, and be able to calculate estimated BMIs, what they are feeding on. And it's effective. It's actually effective. It reduces contact with patients. And then the number of staffs who are donning to see patients, it's also reduced. And I think in this case of COVID-19, we want to reduce our contact with the patient. So I would encourage my colleagues to embrace use of the phone calls for our patients, unless you actually have to see the patients, like for those who are working in ICUs and other areas. But for mild cases of patients, you just call them and have the notes ready, have your calculator ready so that you, as you call, you calculate, you're able to write, you're able to put down their food, take a history, determine what could be happening, and then make a conclusion out of it.
Thank you, Nancy. And it's good that you, once again, you've embraced technology and the hospital is able to provide that and the patients are responsive and receptive of that. Kinati, I wanted to ask you whether you're measuring or assessing vitamin D level for patients at KU. And if you are you boosting the vitamin D levels? That's from Mark Duff or Guido. Hello, Kinati.
Hello.
Hello, yes.
Yeah, at KU Referral Hospital, we are not supplementing any patients who have no indication of deficiency of any micronutrient, because as it was earlier said, there is no sufficient data that recommends a specific supplement over the normal deficiencies. And this can be assessed by a nutritionist who is on the ground, who can look at indicators that might give out a deficiency of micronutrients. And only on these cases is when you might need to give supplementation. However, there has been concern raised about vitamin C supplementation. There are studies that have shown vitamin C supplementation improves immunity, especially for RNA diseases, viral diseases. But for COVID, there is none so far that gives out a concrete direction on how to handle it using micronutrients. So maybe my input will be for any patient who is at home or who is not COVID positive to maintain a healthy diet, and that basically means that you take food that is nutrient dense. You take a variety of foods, not just from one source, as well as you take food in moderation, because while you want to get to have a healthy diet, we get different micronutrients and macronutrients with different advantages to our body from a wide variety of foods. So that will be like what I would advise anyone who is afraid of getting COVID and who thinks that there is a super pill or a supplement that can make you not get COVID. You have to keep safe, wash your hands, wear your mask, and maintain social distancing, as well as eat healthy, drink a lot of water, just like you would have done normally. Thank you.
Thank you, Kinati, for that. Faith, you're saying your patient declined consent. Maybe you can raise your hand and we'll let you share your experience with us and how best you're able to manage that, because I know it's probably a challenge most of us will experience as we try to offer care to our patients using this new technology. Some might not agree to it. Some might still feel the face-to-face or the physical one is better. Others might feel like you're conning them, especially if you're calling them and they're at home and you're in an institution. So kindly raise your hand and we can let you share your experience with us, and then we can see how best do we gain trust from our patients, and how best do we also document that conversation, because a phone conversation might be a bit difficult. As much as you have your pen and paper at that time, there are many other details that you discuss that you might not be able to multitask at the same time record. So those are some of the things we need to address as we embrace technology in this new way we are offering care. Mercy, is the nutritional management for pregnant mothers different? COVID positive pregnant mothers, should we be worried about their nutrition more, or should we just manage them as the other patients and as a pregnant patient without COVID? Should we treat them like the other patients?
That the patients are supposed to take it. We are seeing that there's no specific diet for COVID-19 patients. However, we need to manage these women, our patients, knowing that meeting their needs for the pregnancy. Thank you.
Maybe to add on that, sorry about that. We also manage here at Kenya. Okay. We have a unit here at KNH at the Clinic 66, which was converted to a ward that now caters for pregnant mothers that are now either confirmed or suspects. On their nutritional needs, we only increase their needs by maybe adding their portion and maybe also providing an extra so that they're able maybe to meet their needs. And on the children, you had asked about malnutrition. We have not had many cases concerning the PIDs, but the ones that we have, especially the ones that are just newborns, we encourage the mothers to continue breastfeeding, as well as also we don't even supplement there, but we encourage breastfeeding. And for the ones that can feed now, that is complementary feeds, we enrich their meals. Either, for example, if it is porridge, we can provide special porridge that is enriched with oil, sugar, and eggs. That is now a high protein, high calorie. And then just for your understanding, we also have 42 that also handles issues, cases from the general wards, especially patients that are admitted, or maybe they just came from the casualty. They are received in ward 42, they are tested. Once they are confirmed, either way, now they are moved to the appropriate places. But there we are also managing them in terms of nutrients. We also have Bagati. This is now our biggest unit concerning COVID. And now, initially, we were taking suspects, but nowadays we're only taking confirmed cases. And here nutrition cuts across. We supplement where need be, and we also encourage telecounseling, because we are also provided with the telephone. Now we are able to call the patient in the wards, as well as also going in full PPEs with the laid down structures. Thank you.
Thank you, Jacob. And before we let you go, have you managed any patient who has had loss of ability to taste? Because it's one of the symptoms that we're seeing being when you have presentations, people are saying that's one of the symptoms. So out of all those areas you've mentioned, and the patients you've interacted with, is there any who presented with loss of ability to taste? And also, Kinoti, I'd love to hear whether there's any patient that you've managed at KU who had loss of ability to taste.
Thank you, Dr. Ari. I have managed some few cases of where patients lose their taste and also their smell, especially here in ICU. The ones that can feed orally, they suddenly tell you that they can't smell, they can't taste anything. And this is now where we just encourage them that the taste will come as long as you don't do what? You don't stop eating. We just push that the nutrient intake, especially in water, fluid intake, they improve on that. Thank you.
Thank you. Kinoti, have you managed any patient who's presented with loss of ability to taste?
Thank you for the question, Mercy. In my case, I haven't been able to.
Okay. Thank you. I'll allow George Oguna, Steve Jacob, Felistas Kalonzo to ask your question. We're almost ending our session. You have 5 more minutes, so kindly unmute yourself and ask your question or give a comment. Let's wait for
my question could be, it goes to Nancy. I think she mentioned about exercise. I wanted to know how they do it there at Malay. Because these are patients that are impatient. So how do you ensure that they go for exercise? Is it in the ward or they go outside? And what are the measures?
Let me answer the question. We have red tapes. They have a place they can sit and talk and listen to each other. And then we have a place that has been designated for exercise. We have a physiotherapist who is in charge of that. So they are taken through a 30-minute exercise in the evenings. And they are also encouraged to do an exercise in their rooms in the mornings. So actually we have designated places and it's working well. Thank you.
Thank you, Nancy, for that response. Thank you for that. Jacob, is there any patient who we followed up after discharge? This is from Monica Sitene, and she's asking whether we've done any follow-up on patients upon discharge, especially with regards to nutritional counseling. Have we put in mechanisms to continue managing our patients even from home?
Thank you, Terry. We have no laid structure on that, but we have managed to do a follow-up on several patients, especially the ones that come also with the socioeconomic issues. One particular one was a patient who was diabetic, and she was admitted there for like 6 weeks. So when we followed up, even after discharge, the patient was doing well. At least that one we can confirm that we followed. Yeah.
Thank you so much. And my last question to this team is, what are the Kenyan guidelines saying? You've told us about the Aspen guidelines. What are the Kenyan guidelines saying, especially for patients who are stable? We've had a lot of discussion about patients who are very sick, the severe cases, and that's a very small percent of the COVID-19 patients. Most of them are symptomatic. So what nutritional advice has the Ministry of Health given? What guidelines have they given so that wherever we are, we can still advise our relatives, our patients, and also we can adhere to those standards ourselves? So Alex, kindly let us know what the Ministry of Health guidelines are.
Hello. Hello. Okay, thank you very much. For sure, the presentation I did is for patients who are critically ill, and basically we are applying Aspen guideline. But for stable patients, from Kenyan guideline, we have guidance on nutrition management of COVID-19 for health workers.
Imeisha sasa ni timetable wanapeana hapa.
Okay, sorry. So what is there is that for patients who are able to feed, is that they should be able to eat appropriate meal. That is, they need to take adequate amount of servings in terms of vegetables, fruits, and also and also macronutrient, that is carbohydrates and protein. But as you know, we all know, immune system is not built in a short span. So the general public is encouraged to eat well, and this one should be a lifestyle, yeah, so that they can be able to strengthen their immune system slowly by slowly. And with time, we find that they are able to have strong immune system that are able to help them to fight or to resist infection. Generally, because the guideline has a lot of illustration and types of foods to feed, I would encourage one of us to be able to have a look at it. But in a nutshell, is that we are recommended to eat appropriate meal, that is adequate amount of serving in terms of fruit, vegetables, and also take protein in appropriate amount, starch, and also be able to exercise. Thank you. I think that's what I can be able to say for now.
Thank you, Alex, for that. And we're glad that we have Kenyan guidelines. If the team can share with us, we'll be able to upload them so that the participants can be able to see them or access them. But we have nutritional guidelines by the Ministry of Health for management of patients with COVID-19, both symptomatic and asymptomatic patients. There's a question from Stephen, and I address this to Mercy, and he's asking, is the ministry funding nutrition in the context of COVID-19 research? In terms of research, not for patients, is there any research that you might be aware of that is currently taking place with regards to nutrition and COVID-19?
At the moment, probably Alex can answer the question because I'm not aware of it.
Okay, thank you very much for the question. Perhaps another day I was trying to look for a free journal to publish some work, and I found journals, different journals, they're inviting studies on COVID-19, especially for nutrition, but for now I cannot tell which one specific, but I saw a number of them. So kindly try to check. You can find, if you're interested, you can apply and be able to see whether you can get some funding. But I think it's great time in Kenya, we can be able to, those who give grants can be able to do something so that we can be able to have some studies and be able to come up with a concrete practice in terms of nutrition.
Thank you for that. Kinoti, would you like to say something?
Thank you, Mercy. I wanted to add on a point that a question that you had asked about the Ministry of Health recommendations. In addition to what they have given that Alex has covered, they have given a few pointers on how we can manage some mild symptoms that we might experience at our places. For example, they have indicated that you should take 2 liters or more than 2 liters, especially if you have fever. As well as, in addition to that, coughs, they have indicated that coughs can be relieved by use of honey, pineapple, and chicken soup, by gargling water and hand wash. They have also indicated that sore throat can be relieved by taking tea with honey, ginger, turmeric, and sage. That explains why it is so popular right now. Then again, you can improve the antioxidant levels in the body by use of culinary herbs such as oregano, sage, and cinnamon, and general increase in intake of fruits and vegetables. They have a number of other recommendations, and probably I can share it with you so that you can share with the team that have interest. Thank you.
Thank you, Kinoti, for that input. And yes, we would love if you could share that information with us. You can share it with Mercy, and she will share it with us so that we can upload it, and the participants can also be aware of what else to do. Unfortunately, we were not able to get Daniel to join us. Daniel Muteti from COST, we were not able to hear his presentation, and he seems not to have managed to come back into the panel. And due to time constraints, we'd like to end this session here. Maybe one final word from each of the presenters. That's Alex, Jack, Kinoti, and Nancy. One final word of advice, and also from Mercy before we end the session. Sorry, for some of the questions we're asking about antibiotic use, and those ones we'd like to reserve those questions for another day, because as much as it was addressed to Nancy, probably it's not Nancy who prescribed the antibiotics, so she might not be able to answer you why the patient was put on 2 antibiotics. So bear with us. Some of the questions will be addressed by another team. There's a lot of questions about diabetic patients. We would also love to hear from the physicians. What is the relation? Although we had a presentation a few weeks ago from the endocrinologist about diabetes and COVID-19, and we learned that many patients are susceptible to that. So we'll continue following that up, and I hope your questions on nutrition, strictly on nutrition, were addressed by this team. So one final word, we could start with Alex, Jacob, we go to Kinoti, Nancy, and then we finalize with Mercy.
Thank you very much. Thank you very much. Perhaps for me is that because this is a gray area whereby we are trying our best to provide the best nutrition care, I would encourage each one of us to be able to improve on documentation in terms of nutrition care process, so that we can be able, as time elapses, to be able to come up with solid data that can help us forge the way forward in terms of our operation research. We can be able to have, with well documentation of our patient care, we can be able to come up with something at the end of the day that can help us be able to provide a better care than currently we are doing. Thank you.
Thank you. It was an honor to be on board. And what I would say is just to encourage that we read more, study more on the COVID, so that we are able to help our patients, so that they can, we are able to help them recover quick and also manage their condition. Still, I would suggest that we continue having such sessions only for the betterment of handling cases of COVID. Thank you.
My parting shot will be to thank the organizers of this forum. It has been very helpful, sharing the experiences from each and every institution. I would like to reiterate the comments of my colleagues. Yes, we need more of these sessions about nutrition so that we can have a common pool of knowledge of how we should move forward on managing patients and giving them nutrition therapy that suits for them. Therefore, I'd like to appreciate everyone who has taken part, the organizers, and everyone who has been a key player in this, and encourage that we have another of these forums soon enough. Thank you.
Okay, from Uasin Gishu, this is Nancy. We want to say thank you for including us in this program. I'm here with my colleagues, although they were silent. One thing that I would want to bring out, when you're dealing with mild cases, lack of food brings stress to them. So it's important for the nutritionists involved to let the management understand the issues of food service management, ensure the procurement, ensure that you have enough food for patients, especially the stable, those who are stable, those who can take care of themselves and move around. You'd realize they demand for food. They demand for things that you cannot even supply, because normally, actually, they are not sick. In fact, we say in our station, these patients are not sick because they are symptomatic, they're okay, they want to play around, they want to eat. So food provision is very key and very important, that it needs to be planned for. And I realize when you miss to do that, you end up in trouble with patients. And you realize those are some of the issues the people are dealing with psychosocial support actually wanted the nutrition department to address. And you realize you can't do it alone. You need the administrations, because they're the ones that buy and plan and give you what you require. You plan and they buy for you. So those are issues that must be handled and taken care when you're dealing with mild cases and asymptomatic cases. Thank you.
Sorry, thank you so much. My parting shot is that as a nutritionist, we need to, for general population, we need to eat and so that we boost our immune system. And by doing so, we need to take plenty of plant-based foods like fruits and vegetables. We need to stay safe in terms of when you're going to shopping. You need to adhere to distancing. We need to look at sanitizing everywhere you touch. And again, you need to take plenty of water, 2 liters and above. And also exercising is very important. Like every day, 30 to 1 hour, make it a routine to do exercises. And also balance your meals. Don't eat one type of meals like carbohydrates. There's a question which somebody asked, like how much carbohydrates, how much proteins. And that one was covered in our presentation. And I'm asking that, I'll request that we balance our meal. Thank you so much. See you soon.
Thank you. I'd like to thank this team for finding time and coming to tell us more about nutrition, what we need to advise our patients to take, and how best to manage ourselves also and our relatives. So thank you to this team from nutrition. You've done a fantastic job, and we appreciate that you've enabled us to your experiences from other facilities. We appreciate Uasin Gishu County, Kimalel Isolation Site. We appreciate Coast General, as much as we've not heard from you, but we appreciate Daniel for the effort that you put in, and Kenyatta University Teaching and Referral Hospital. We appreciate you, Kinoti, for that. We also appreciate the frontline workers like Jack from KNH IDU facility. We appreciate all the effort that you put in place. Healthcare is a multidisciplinary system. We cannot do it one way only. We cannot just give medication. And I can see Jojo Witty is saying he's appreciated that management of COVID is not just one way, that there is also the nutrition side. And he's saying, thank you for offering me an opportunity to gain this knowledge. I thought medications were enough for managing COVID-19. So we appreciate this team very much and continue doing the good work that you're doing. You're doing great. Tomorrow we will have a Mental Health Thursday. My co-host, Dr. Ngumba, will take us through coping with stressful conditions. She'll be the co-host for that session. We'll see you tomorrow. Thank you for logging in. Thank you for your time. Bye.